So basically this month's topic is a bit of an ongoing kind of learning topic from back in January when we did Suboxone, buprenorphine as an opiate agonist therapy. So basically this is a little bit more of a discussion. I've been involved with a provincial working group for our site, involved kind of in trying to create some strategies around tackling this issue. And so we'll kind of discuss that a little bit more at the end of the round's presentation with regards to particularly microinduction of Suboxone from the emergency department and what that is likely going to start looking at, because the pieces are finally kind of starting to fall into play with getting a new order set for Northern Health, etc. So as usual, currently still have nothing to disclose, no conflicts of interest to declare. For this presentation, I really wanted to just kind of focus on three things. The first is going to be kind of review of opioid use disorder and opioid withdrawal, which for most of us will be more of a review rather than necessarily learning new things, but I just wanted to kind of cover that to get everybody on the same page. The second thing was discussing acute pain management in patients with opioid use disorder, because I know that this is something that occasionally is a bit of a struggle in the approach and how best to manage acute pain. And then the third thing will be basically interventions for opioid use disorder from the ED, primarily focusing on induction of naloxone, buprenorphine, or Suboxone. Keep tapping my keyboard. If anybody wants like a little bit more of a kind of nitty-gritty, specifically looking at opioid agonist therapy, so specifically for Suboxone, for methadone, as well as injectable opiate agonist therapies, the Provincial Opioid Addiction Treatment Support Program called POTS-P, that's offered by kind of the BC Centre of Substance Abuse, is a free online kind of CME activity. It says it takes 5 to 6 hours. I probably did it myself in about 3 to 4, but is a really good kind of takes you through a little bit more of the details with regards to particularly Suboxone and methadone. And I found it's actually been quite helpful for practice in the emergency, and kind of helps to guide questions with addictions and other service providers around kind of issues that crop up with patients with opioid use disorder. So first thing, identification and management of opioid withdrawal. We all, generally know in terms of kind of what we're looking for, a time frame, that there's a difference in symptom onset, usually between short-acting opiates like fentanyl or even hydromorphone compared to the longer-acting opiates like methadone. And basically, kind of for those shorter-acting, patients may start to go into withdrawal around 6 to 12 hours after their last use, compared to methadone, where it may be more like 30 hours, with kind of peak onset of those symptoms occurring usually around the 72-hour mark of where they're having their maximal severity of symptoms. Now, opioid use disorder did get redefined in the DSM-5 criteria. They used to kind of separate out these criteria basically into dependence types of symptoms versus other categories. They've just combined them all, and essentially for a diagnosis of opioid use disorder, a patient must have a problematic pattern of use that leads to a clinically significant impairment or distress, with basically 2 of the following 11 criteria occurring within a 12-month period. And I think, like, if you read through that list, most of us, when we're having discussions with patients who do have an opioid use disorder, can kind of appreciate that, definitely most of those patients likely have more than 2 of them, but that's basically just the diagnostic criteria that is there. And when you read studies regarding opioid use disorder, this is the criteria that they use basically for entry into those studies regarding the opioid use disorder. So withdrawal symptoms, again, nothing that's going to be new to any of us. Basically kind of multi-system involvement. Probably the most prevalent that we really see kind of on a day-to-day basis in patients that might have this are basically kind of those neuropsychiatric symptoms, the irritability, restlessness, tremor, insomnia, the cardiovascular, the tachycardia and hypertension, and then the GI symptoms with that kind of nausea, vomiting, diarrhea. The reason that kind of addressing and knowing kind of withdrawal symptoms is important because at the end of the day, that's basically how we determine the severity of opioid withdrawal that a patient is in. And this is done by the COWS score. So the COWS score is something that our nursing colleagues are very familiar with regards to kind of their ongoing management and assessments of patients that are either in their emerge or admitted to the hospital. And basically is comprised of a variety of scoring criteria, essentially looking at things like heart rate, degree of sweating, restlessness, pupils, aches, GI symptoms, presence of loose flesh, and each of those criteria are basically scored on a scale of somewhere between 0 to 5, with the end score essentially putting them into a category of whether they're mild, moderate, severe, moderately severe or severe withdrawal. And basically mild is less than 12, moderate is kind of like 13 to 24, moderately severe 25 to 36, and severe withdrawal greater than a score of 36. Management options and our opioid withdrawal or opioid use disorder order set that we have on the back of the initial page where basically the buprenorphine Suboxone induction kind of order set is, there's some really good kind of just like checkbox options that are basically what I've got here on this slide. So kind of the main ones are kind of medication based or things like clonidine, kind of our usual kind of Tylenol, Advil, Gravel, Zofran, loperamide for diarrhea, and then kind of trazodone, olanzapine, loxapine for those kind of neuropsychiatric, agitate, insomnia types of symptoms. And then other things kind of to just kind of be aware of or consider in management is whether the patient needs IV fluid hydration, if they've really been having significant nausea, vomiting, diarrhea, keeping track of their QT, particularly as you're starting to layer on some of these medications, or potentially if they have other substances on board that aren't opioids, but particularly maybe if they've been using methadone kind of as a non-opiate agonist therapy, use of the Narcan kit kind of as needed, and then consideration of opioid agonist therapy, which we'll go through a little bit more later on. Complications of opioid withdrawal, and I think kind of going through my medical training anyway, you kind of classically learn that compared to alcohol withdrawal, that opioid withdrawal, isn't life-threatening, isn't going to cause significant harm and those types of things, compared to like the potential for seizure, delirium tremens that alcohol withdrawal holds. But there are still some fairly significant kind of morbidity, mortality outcomes that significant opioid withdrawal can result in, from things that, you would expect with severe GI symptoms like dehydration, electrolyte abnormalities, to kind of some of the more severe cardiovascular. Patients can potentially manifest like a stress cardiomyopathy, like a Takotsubo. They can end up with QT prolongation through treatment, pulmonary edema, particularly for those patients who do have underlying coronary artery disease. We know that opioid use disorder is not necessarily a disease of kind of young people with no medical problems. A lot of these patients do carry comorbidities that are either substance related or not substance related. And then additionally, opioid withdrawal does carry significant risk of overdose and suicidality and death by suicide, essentially, just because they either can't deal with their symptoms anymore and decide to use kind of another means, just because of some of the other psychiatric kind of comorbidities that go along with opioid use disorder, in particular like depression, severe anxiety, psychosis, etc. Opioid use disorder is also really important to consider in pregnant patients. When you look at the literature, pregnant patients in particular have quite significant high rates of relapse, which puts them at higher risk of overdose as well as an increased risk of bloodborne diseases. Withdrawal in a pregnant patient does significantly increase the risk of kind of perinatal complications, including preterm labor, intrauterine fetal demise, growth disturbance, etc. And for pregnant patients that do present with significant withdrawal, or if they may be a patient that we're considering who wants to be initiated on opiate agonist therapy, there is some good literature supporting that often this particular patient type may require actually admission to hospital, in concert with collaboration with obstetrics, gynecology, and addictions to be able to safely manage their withdrawal symptoms and or induction on a form of opiate agonist therapy if that is their desire. Precipitated withdrawal is a very real phenomenon that I think every one of us that's worked in the emerge can appreciate. The most common circumstance that we will see this in is particularly in a patient with more chronic opioid use disorder that ends up getting naloxone either pre-hospital or in hospital, and they get kind of that immediate onset of severe opioid withdrawal symptoms. At the end of the day, treatment for this is supportive. And again, I think we've all experienced this patient that they end up getting Narcan, and then we end up kind of chasing our tail a little bit sometimes, with regards to managing that precipitated withdrawal and trying to get that under control, because these patients often end up being very agitated and in quite significant distress. The biggest thing with precipitated withdrawal is to not give opioids for the same reason that we watch patients after they've been given naloxone. Giving kind of doses of opioids to try and get on top of their symptoms may actually result in the patient having an overdose, particularly if they decide to leave against medical advice after they've been given the opioid and maybe their symptoms are slightly better after the naloxone wears off. They're at quite a big risk of that. So that's the main kind of recommendation with regards to precipitated withdrawal. In the same way for opioid withdrawal, we don't directly give kind of opioids that are not opiate agonist therapies or treatments. That kind of goes the same with regards to precipitated withdrawal. So I'm going to move on to pain management in opioid use disorder. And I think, again, it's not really surprising to anybody that patients with opioid use disorder do commonly experience episodes of acute pain, whether that's related to injury, kind of other illness, or perhaps they've required surgery. And basically, particularly those patients that are on opiate agonist therapies, there's kind of a lot of, difficulty and kind of uncertainty with regards to how best to manage these patients. Just as kind of a general reminder, methadone itself as an opioid agonist therapy is actually a full mu receptor agonist. So it does generate some level of opioid effect when it kind of interacts with the opioid receptors, compared to buprenorphine, which is basically a high affinity partial agonist. So buprenorphine gives basically some activation of, in particular, mu receptors, but doesn't kind of quite drive the same kind of other, things that people are looking for with opioid use disorder, usually like the euphoria and those types of things. So buprenorphine doesn't have complete effect on the mu, but basically tends to be higher affinity for the mu receptors, and then basically blocks them. So it's a little bit more difficult to get good analgesia sometimes in these patients because of that. Hyperalgesia is definitely a very real phenomenon that we see with opioid use disorder patients. Particularly to very kind of limited stimuli, I would say. This basically, this kind of graph here is from an experiment where essentially they took patients that did or didn't have opioid use disorder who were being treated on methadone, and basically put like a cold pack on their skin, and basically timed how long they could actually kind of withstand the kind of pain stimuli from having that cold pack put on their skin. And as you can see, kind of the patients that are kind of on methadone basically have quite a significant kind of difference with regards to their kind of tolerance of pain and duration that they're able to kind of tolerate that stimulus, which I think, you know, kind of even doing like minor procedures in patients who may have opioid use disorder, like a IND on an abscess, you know, these patients often have a lot more pain experienced from something like local anesthetic infiltration, etc. So this is a very real phenomenon, and you know, given that occurs with more kind of small or kind of less kind of painful stimuli, you can imagine kind of what their pain response to kind of more significant noxious stimuli is going to be. So with regards to this, I think basically there's kind of 4 key points for these patients who are presenting with acute pain. Their baseline opiate agonist therapy is not considered to be adequate analgesia. Basically, that holds them at their kind of normal baseline, particularly patients who have been on opiate agonist therapies for a longer period of time, and it will not be enough if they have kind of an increased level of kind of painful stimuli there. You know, this kind of idea about giving kind of opioids in ED or post-op or whatnot, you know, causing high risk of relapse is not true. When you actually look at the literature, opioid use for analgesia does not increase the risk of relapse for patients, particularly those who are stable on opiate agonist therapies. There is a limited risk of oversedation for patients who are stable on OAT. So if they're on, you know, a decent dose of methadone, they've been on that for a while, or they're on Suboxone, it's usually quite difficult to actually get them to kind of swing the complete other way. And basically the kind of analgesic that tends to be recommended most in the literature is hydromorphone, kind of over other things like morphine, codeine, etc. Most of the literature supports the use of hydromorphone. So methadone, kind of pain management in this patient type is very similar as those who take stable doses of other opioids on a chronic basis. The idea basically is to continue that baseline kind of opioid and dose. So we would kind of have them on their usual methadone dose, and potentially kind of considering multimodal use of non-opioid analgesics with incremental opioid use during kind of their interval of pain, and then kind of after their pain is settled, kind of tapering that dose of opioid. Patients on methadone, I think not really surprised to anybody. They do get a lot of opioid cross-tolerance, so they usually will require higher doses than, say, an opioid naive patient, or even a patient maybe who is on kind of less kind of higher potency long-acting opioids. So just something to kind of keep in mind, you know, with this patient subset. This isn't something that's necessarily directly for eMERGE, but often you will see patients who maybe have chronic pain syndromes who are on methadone also on gabapentin. And the reason for this is that basically gabapentin has been shown to reduce that kind of hyperalgesia that patients on methadone get, and doesn't interfere with the metabolism or kind of slow it down kind of for the methadone. So, you know, maybe something maybe for us to consider here and there. It's obviously not going to work, you know, in an immediate sense, but is a reason that you might see patients that are on methadone also on gabapentin. With regards to kind of opioid dosing, you know, if a patient is requiring opioids kind of for more kind of moderate to severe pain, the general recommendation after pain is kind of acutely gotten under control is that you kind of basically allow the patient to have short-acting oral opiates on a scheduled basis and not on a PRN basis. So basically they kind of get their, medication dose every 3 to 4 hours, kind of around the clock. And they only have admitted doses if sedation or respiratory depression are observed. And this is basically kind of for that idea of trying to get the patient to a more kind of steady state kind of level, rather than kind of ending up kind of wearing off, getting in pain crisis, needing kind of higher doses, and kind of going through the cycle. Now with buprenorphine, similarly to methadone, it's important that it should be continued kind of during their episode of acute pain. Again, like methadone, you're going to need to anticipate that higher than normal doses of any full mu agonist like hydromorphone are going to be required for pain control. For mild to moderate pain with buprenorphine, again, just like we would kind of go up the usual kind of pathway, consider non-opioid adjuvants. There is an option for mild to moderate pain to consider increasing buprenorphine and ending up in divided doses. I would suggest that if you're kind of thinking that might be an option, to perhaps discuss with one of the addictions docs or even the docs on the race line that are basically there kind of 24/7 to give advice with regards to addictions. But that may be kind of an option rather than potentially needing to start them on like a full mu like hydromorph. The thing that kind of people get concerned about with Suboxone is because of the naloxone, but really that naloxone is minimally bioavailable when it's kind of taken as the sublingual wafer. So that aspect of it won't interfere with your pain management unless the Suboxone ends up getting injected. You will start to see some patients who are actually on like an implant depot type of buprenorphine naloxone. I think it's called Sublimat. There are some patients right now in Prince George that are on this. I think just actually ended up getting coverage through MSP, so it kind of will be something that we may start to see. The biggest thing is really like for these patients, you can't adjust the dose of buprenorphine, so really your only option if the patient's needing more than non-opioid analgesics is to basically supplement with something like hydromorphone as needed. For severe pain, again, you're probably ending up kind of needing either oral or kind of IV sub-Q full mu agonist. And similarly to methadone, you want to be giving this more on a regularly scheduled dose versus on a PRN basis. So just as kind of a general summary for outpatient analgesia, we're continuing whatever kind of the OAT therapy is, optimizing multimodal analgesia as appropriate, so acetaminophen, NSAIDs if the patient can tolerate them. And in general, the literature basically says if you need to give the patient opioids to help with their acute pain kind of situation, that you only give a max 3-day course and preferably of PHO hydromorph. I will admit I'm guilty of the Tylenol with codeine prescription, but there's actually really good evidence if you look just in general at pain literature that really Tylenol with codeine doesn't have really any better effect than Tylenol and Advil anyway. So if patients are really requiring something stronger, the advice in the literature is to actually use hydromorph, particularly in this patient subset compared to one of these lower potency analgesics like Tylenol with codeine or Tramadol. Inpatient analgesia, very, very similar kind of initial steps, continue the OAT, optimize multimodal. In these patients, this might be a place, depending on what the issue is, to consider nerve blocks, perhaps kind of speaking with our anesthesia colleagues or kind of doing that ourselves. Ketamine is also one that's big in the literature with regards to kind of management of more severe pain in hospital. This is obviously obviously very center specific. I think we'd have a big issue if we just tried to start using ketamine for pain management from the ED, and the patient would never end up going up to the ward because of that. But it is something kind of that we might see kind of start to come down a little bit more. There are definitely some American centers that are looking at this, as well as some of the bigger Canadian centers. And again, for inpatient, it's about titrating that hydromorph to achieve adequate relief, and then basically starting them on a scheduled dosing of an analgesic. So opiate agonist therapy in the emerge. This is kind of the kind of bigger new topic for our department anyway. This is not new to emergency medicine by any means. There are a lot of centers, particularly in kind of Vancouver, Victoria, and Edmonton, out in the West anyway, that are quite kind of well established with regards to initiating opioid agonist therapies from the emergency department. It's been something that has been a little bit difficult to kind of get all the key players involved in, particularly during kind of COVID, but it's something that's finally sort of come together to a point where we'll likely have a new order set and a new protocol pretty quickly, and I'll discuss the one that kind of has been the most recent that'll likely be going out to key stakeholders fairly soon. So the idea of opiate agonist therapy from emerge is really kind of a part of this bigger discussion around harm reduction from the emergency department. I think, again, this is something that we can all, from experience say is something that's definitely been an increasing problem over the past kind of 12 to 24 months, kind of from the initiation of the opioid epidemic, which really seemed to take off kind of in parallel with the COVID pandemic. There's essentially a spectrum of strategies, including safer drug use, managed use, abstinence. And the idea of harm reduction is really kind of meeting people where they're at without leaving them where they are. And so basically kind of offering kind of what we can to try and help these patients. There's lots of kind of pieces towards this. The ones that I've highlighted in those yellow boxes, like naloxone, medication-assisted treatment, and referrals, are basically the ones that our department is kind of actively undertaking at this point. And then, essentially we've got kind of community services like the needle exchange, and the detox kind of addiction center that have kind of more of some of these other things. The thing we don't really have in our hospital at this point is a supervised consumption service. That is something that some of the bigger hospitals around actually have integrated for their inpatients. So like the Royal Alex in Edmonton actually does have a supervised consumption site on their hospital property that can be used by inpatients. So if they're kind of medically stable enough to kind of leave their ward, they're able to kind of go and access that service, as well as, there's some programming down in Vancouver as well as in Edmonton. Edmonton has a program called ARCH program that is a little bit more focused on addressing some of the kind of more significant social determinants of health. So things like housing, patients having an ID, and all of those types of things. So there's definitely some really great programs. From a resource perspective, we're not quite there. And, from a emerge basis, really what we have is we've got the naloxone kits, we've got the opportunity to kind of initiate patients on opiate agonist therapies, and then kind of referrals. If you remember from our journal club back in January, the referral and kind of handing patients a piece of paper that says here are kind of the resources doesn't tend to be super effective, and it's more about kind of more aggressive follow-up. So that's something that we've been trying to kind of engage with our addictions colleagues about. Even something as simple as, sometimes they get referrals and they try to call the patient and the patients don't pick up the phone because they don't recognize the number or that type of thing, to moving to something like texting that patients do tend to kind of be able to interact with a little bit more than phone calls. So those are some things that are in the works from that perspective. With regards to medication-assisted treatment, we've talked about the first two, which are kind of the more common ones, so methadone and buprenorphine naloxone or Suboxone, which is available via oral or injection depot. You will have also seen patients who are on Cadian, which is essentially a long-acting morphine, and something that I don't think many patients within Prince George are on, but is certainly something that is being done in other centers when patients have usually failed these alternative kind of methadone, Suboxone, Cadian options, is intramuscular hydromorph, which is referred to as injectable opiate agonist therapy. So Edmonton in particular has some patients that are on IM, which basically they get, I think, TID kind of over the other options. So again, just as a reminder, particularly for buprenorphine, it's a partial agonist, which kind of generates this kind of limited opiate receptor effect, but also has a high affinity and basically kind of blocks that mu receptor. Buprenorphine naloxone is prescribed in a 4-to-1 ratio of the buprenorphine to the naloxone. It is sublingual, so if you've ever seen the tablets or the wafers themselves, they are actually quite fragile, which will be kind of a part of our discussion about microinduction and why sometimes that's a little bit difficult and why it's taken some time to figure out. But it's given sublingually. Basically, it is a synthetic partial mu agonist and has a higher affinity for mu receptors than other agonists like heroin. So a benefit of buprenorphine in particular compared to methadone as an opiate agonist is it does have a protective effect against opiate overdose in particular, just because they won't get the same effect of the other substances. And this is basically just a diagram, again, of kind of opiate effects. So basically naloxone kind of across the board, regardless of the dose, doesn't have any impact. Buprenorphine, actually, because it is that partial agonist, basically kind of stimulates the opioid receptors to a certain part and then basically develops something that we call a ceiling effect, where it doesn't have any ongoing increasing opiate effect and basically just kind of levels out, compared to methadone that I think, we can all kind of appreciate as doses go up. If a patient's not tolerant to that particular dose, they will get increasing opiate effect at higher doses. These are just some good videos if you want to brush up on your pharmacology with regards to partial and full opioid agonists that are available basically through the same POTS-P course that I linked on the first page there. So out from the ED, when we look at the literature, basically the recommendation from emergency is that buprenorphine naloxone is really to be considered the first line option for opiate agonist treatment because of this kind of ceiling effect. It has a superior safety profile compared to methadone, and it doesn't carry kind of all the other like potential long QT, et cetera, that methadone has. It can be initiated in Emerge or as kind of what's called a take-home kit. And then basically there's two general kind of ideas of protocol for induction, which is traditional versus microdosing. This is an example of what we have right now, kind of on our opiate kind of use disorder stuff, which is basically the more traditional Suboxone induction, which basically on day one gets them up to a maximum dose of 2 milligrams of buprenorphine in 24 hours, and then kind of is done basically over a 3 to 4 day period to get them up to basically with their stable quote unquote dose. The problem with this, as I'm sure everybody's aware, is that this it requires patients to be in a fairly significant amount of opiate withdrawal. So they actually have to be in more moderate withdrawal. If they're only in mild, which would be a COWS of less than 12, essentially they either have to wait until they're over in more significant withdrawal, or they're at high risk of ending up in precipitated withdrawal just because of the buprenorphine effect, basically, which is all of a sudden kind of lowering the effect of the opiate and kind of blocking off those receptors without the same activation. And that's something that's very real. If you kind of discuss kind of with some of our addictions colleagues, it's something definitely that they're quite conscious of. And is one of the reasons why there's been a lot more discussion about this microinduction protocol, particularly for, say, pregnant patients, like we mentioned before. Kind of traditionally, buprenorphine naloxone was considered a less optimal option, just because patients had to enter into having active moderate withdrawal, which for a pregnant patient, again, increases their risk of kind of prenatal or perinatal issues because of that withdrawal kind of that they get. So a lot of those pregnant patients in the past, kind of methadone was actually the preferred option for management of the patient for opiate agonist treatments. But now kind of with this idea of microdosing, where a patient doesn't actually have to be in such significant active withdrawal, that may be something that we start to see a little bit more in that particular population. But just in general, overall from Emerge, where sometimes it's a little bit difficult to truly know what the patient took when they last took it, etc. Kind of doing this traditional induction can be a problem, and kind of one of the really kind of significant downstream consequences of precipitated withdrawal is because patients end up feeling so horrible with it, they're at much less likelihood of being receptive to trying it again in the future. So that's kind of, again, kind of one of the issues. If you have a patient who's in moderate withdrawal, their COWS is greater than 12, it is okay to do the traditional. There is still risk of precipitated withdrawal that's higher with it, compared to microdosing, but is an option. So microdosing, again, just like we talked about, really the limitation to that traditional dosing is that patients need to abstain from opioid withdrawal for a period of time. And depending on the drug that they used, that can be anywhere from 12 to 36 hours because of that risk. Microdosing is basically a slower process. You'll see it referred to in the literature as the Bernese method, which is essentially an induction of over 7 to 10 days. That's much more gradual and slow compared to the 3-day induction of the traditional. This is one of the examples of the protocol, and the next one has the one that we're potentially considering for Northern Health. But basically, it's a really small dose on day one, which is 0.5 once a day, followed by 0.5 twice a day, 1 milligram twice a day, etc., all the way up to day 7. And then essentially, after that time, the patient's dose will get escalated up to kind of what will likely be their stable dosing as per their symptoms kind of over time. This is basically kind of what's currently being proposed for us. And again, at some point, once there's been a little bit further discussion, though likely will be kind of a thing that goes out to the stakeholders. So this is proposing a 6-day, with day 1 basically being that 0.5 milligrams twice, followed by 1, by 2, by 3, by 4. This is essentially what the patient will end up getting handed to take with them with regards to the instruction. And so you can see basically kind of here, that 0.5 milligram dose is actually a quarter of a tablet. So there's been actually a lot of work with basically our Emerge pharmacist, Jen, taking the tablets and basically trying to make sure that they remain stable and they don't just break apart when they're in such a small piece. This actually physically requires that either pharmacy or nursing divide those tablets kind of as indicated here. And so that's a part of this. Like I have done this from the Emerge. I had a patient one day when I was the streaming physician. Dave wasn't here. Dave is often very happy to help make up these microinduction kits if he's around, but he wasn't around that day. So I had one of the nurses do, and it does take about 10 to 15 minutes of time basically to cut all the tablets, to label them, etc. So the idea for us is that we will have pre-made induction kits that we can basically give the patient kind of the handout, have a bit of a discussion with them about the protocol, give them it so that they're able to go. They can take the first dose and Emerge, or they can wait until they're home, depending on what they want to do. And then the idea after we send them with this kit is that we will basically send off like a referral form like we do for, say, rapid access medicine, that will go to the OAT clinic, basically in the detox building, for them to then kind of follow up with the patient. But this is the current one, so you may see this kind of go around. But in my discussions with Dr. Ferdin's kind of been the primary one involved with us for the Emerge side of things, is this is generally what that addictions group has agreed upon as the proposed microinduction protocol for us. Patients, this is just the kind of top end of that same handout, basically kind of with, information, expected side effects, etc., and kind of with regards to kind of how to connect with the OAT clinic in that side of things. So OAT for inpatient, I think this got mentioned by Jen at our department meeting. It is safe to continue stable current dose for all OAT therapies, so regardless if that is buprenorphine or methadone or Cadian. But the important thing is just to check when the last dose would have been dispensed. As kind of she brought up at our department meeting, there have been some cases where patients have been prescribed their methadone dose that they maybe haven't taken for a week. There is, in the POTS-P goes through it a little bit more specifically, or you can talk with addictions, but essentially, particularly for methadone, because it is so long acting, there in general is a recommendation that if they've missed a certain amount of days, that we actually half their restart dose rather than continuing them on their full dose, just because they are at risk of oversedation because of that. Suboxone usually isn't quite as much of an issue from that perspective, but if they say have been using other opiates while they've been off that Suboxone before they get admitted, and you try and give them their kind of old dose of Suboxone, and it's been a couple days, that won't be in their system to the same extent, particularly if it's been more than like that kind of 3 to 4 day mark, and they're at risk of precipitated withdrawal because of reinitiation of that high dose. So those patients usually either would need to restart if they're in withdrawal, kind of on that traditional protocol, or be microdosed back up if they wish to continue on that as an opiate agonist treatment. In terms of resources specifically, we all know kind of our addictions kind of physician group, and so I found kind of, particularly since I've had a little bit more awareness of some of this, I've been able to have a little bit more educated discussions with them and more kind of specific questions with regards to the options for microdosing, etc. Dave Rootley is also a really great resource, and he's very, very keen, as is Jennifer Day, our pharmacist, to help out with regards to kind of particularly initiating patients on opioid agonist therapies. And then there is also kind of this race line, which basically does have 24/7 addictions physician availability for questions and consults. I haven't personally used it. Jen Day has on a few occasions. So it is something that's also there. Depending on I don't know, if there was a day that we didn't have addictions coverage or something, to have those conversations. So the key points, basically, opioid use disorder has very specific criteria. So just kind of have an awareness of that. We want to monitor severity of opioid withdrawal using COWS. Severe withdrawal may need to be required as an inpatient, particularly in pregnant patients. Analgesia is important for patients with opiate use disorder, whether they're on opiate agonist therapies or not. In general, hydromorph is the suggested full mu agonist of choice. Expect that higher doses are going to be required, particularly for patients who are on Suboxone, and consider regular dosing over PRN once you've gotten kind of the patient's acute pain a little bit better under control. And Suboxone is the method of choice for opiate agonist treatment from the eMERGE. Microdosing is by and large starting to become the preferred approach for this from the eMERGE. And really it's kind of going to be creating that link between eMERGE and the community to make sure that these patients are getting followed up to be continued or have their dose increased. So really our job is to kind of initiate some of that initial discussion if patients are interested, potentially starting them on Suboxone microdosing from the ED, and then kind of creating that link, and hopefully Lawrence Verdeen was working on whether that texting option might be something that they're able to do just to try and get some better contact with patients to make sure that they're getting followed up with, whether it's there, maybe they're a central interior or blue pine patient, which do tend to be happy to follow patients on these therapies. That is all I got for today. Any questions? I see Matt race. So I believe the race for addictions is available to everybody. So it's available for inpatient as well as emergency medicine access.
Hey, Melissa, can you hear me?
Yep.
I was just wondering kind of maybe to poll the group about some practical aspects. So, yeah, kind of the titrating up dilaudid for acute painful conditions on paper, makes sense, works very well. I found particularly like when I was on IDAO, this came up quite a bit and is quite a nursing burden. I was just trying to maybe poll the group to see kind of what they've had success in doing, particularly when people come in using illicit opiates, which is harder to quantify, like what your starting point of hydromorphone should be. Just as an example, I had a guy on the wards on IDAO who was actually taking instant release oral hydromorphone in the community. So it's like, oh, this is a great starting point. He was taking 30 milligrams per day, just as PRNs throughout the day. And even that took about, 24 hours to get him on a pretty good regimen, even knowing our starting dose, because I didn't want to go straight to, we gave him 30 as the baseline, but getting up to his PRNs for his femur fracture was a very large nursing burden. So I'm just wondering kind of what types of doses people are using in the eMERGE for acute painful conditions, particularly when people come in using like heroin or fentanyl that we can't really quantify. Hello?
I don't know if anybody else was gonna jump in or not.
Oh.
I mean, yeah, I think definitely, really difficult. I mean, we can even, think like of patients that do end up in just pain crisis, like who don't necessarily have an opiate use disorder. So like sickle cell patients, for instance, and I think that it's really difficult to figure out that dose titration, particularly if a patient is really taking that much. I don't know if I've encountered quite as severe of a patient. I had a patient who ended up with a really bad tib fib fracture that, to get control of his pain initially, like he was getting like 2 to 4 milligrams IV, and in Emerge, like, and that's what he ended up kind of eventually getting titrated up to try and get him relief. And so, I think like there's not going to be a straightforward answer, just because it's going to all depend on like how chronic is it, how much is it, when's the last dose use. Like there's so many questions with regards to like how to figure that out. And then, at what point do you make the decision to like say switch onto a long acting after you've sort of figured out like whatever their baseline need is. That might be a patient that would have been really good to speak with addictions about to figure out like what are the options. In some of these cases, I have seen them initiate methadone to try and get that baseline, and then using hydromorph on top of that. But yeah.
Yeah, me and Lawrence chatted quite a bit that week about this gentleman who was in no way interested in agonist therapy.
No.
But anyway,
the patient was.
We got him to a comfortable spot, and then